Good evening, everyone. Uh, it's yet another day and yet another session of the Foxy Presidential Initiative of Podcast, the Gyan Pravah. And we are really happy to announce that today is the 50th episode of the Gyan Pravah series. And we're really thankful to our president, Dr. Sunita Tandulwadkar ma'am, who has given us this platform, this opportunity to conduct this podcast day in and day out, that is, day after day, over this period of a year that she plans to conduct these sessions. We are also quite blessed today that today we have our President Sunita ma'am herself at Puri at the Arogyam Yatra Darshan, and we are going to get straight blessings from Lord Jagannath for this program as well, for us as well as all our listeners today evening. So today with us to start off with this session, we have none other than Dr. Ashwini Kale, who's a renowned embryologist, renowned gynecologist, joint secretary of Foxy currently, and a very good friend of mine. She is working very dedicatedly for Foxy. She has worked very dedicatedly for ISAR and other organizations in the past as well, and also continuing to do the same. She's the managing committee member embryology of ISAR as well. So I welcome you, Ashwini, to this platform. And today we're going to have this series on the topic endometriosis, the enigmatic disease, all knowing that endometriosis month, this is the endometriosis awareness month, and that's why we thought we'll do this topic today. We have with us none other than Dr. Sandesh Kade sir, who is the director, Advanced Gynecological Institute at the Burjil Medical City in Abu Dhabi, and he is currently in India, in Solapur, of course, his home. And thank you so much, sir, for joining us. And we request
Thank you.
Ashwini to kindly give us a brief of the series and also welcome all of us for this program.
Good evening, everybody. It's a proud privilege to welcome Sandesh sir, and I must say that he was here with us in Pune operating just last Friday. So I must say that we are very lucky. And today is Ranga Panchami here in Maharashtra. So it would be the yellow colors of endometriosis around. And who better than Sandesh Kade sir himself for this series on endometriosis? So basically, Foxy for the first time has started this series of podcasts where every day one chairperson interviews one of the person who are experts in their field, be it medical science or even social fields, for a crisp 40-minute interview. And we are doing it live every day dedicatedly. Sunita madam herself joins in every day, but today she is on the stage at Arogya Yoga Yatra at Bhuvaneshwar, which is another project of hers where we are touching spirituality in medicine. And every month we do it at one or the other place. So in Jan we started with Tirupati. In February we were at Rishikesh. Now, March, we are in Bhuvaneshwar. April, we will be at Shankaracharya Temple at Srinagar. So, there are 13 dedicated places that we have selected. So, next year in Jan, this yatra gets over. And another one of the projects that Madam is very passionate about is Sampurna, which is the preconception care, which is the foundation for every pregnancy. And her tagline for that is Swastha Janma Abhiyan, is that every pregnancy should be planned. And I'm very happy that today Sandesh sir is going to throw some light on endometriosis, which we are seeing on the rise. And these young patients, they also suffer a lot from endometriosis these days. And these poor girls are so symptomatic, but luckily, at least they come out and talk about it openly now. So, probably diagnosing them and treating them has become easier. So, over to you, Priyankur, to interview Sandesh sir, and I'll happily listen from the viewers' link. Thank you so much, Sandesh sir, for joining us. And this
Thank
is
you so
our
much.
50th episode. So half a century today. Thank you,
Absolutely.
sir.
Congratulations.
Yeah.
Thank you so much, Ashwini. Thank you so much, Sunita ma'am, once again for giving us this opportunity. And I once again welcome Sandesh sir to this platform for this wonderful series. So, Sandesh sir, he is the director, Advanced Gynecological Institute in Burjil Medical City in Abu Dhabi. He's an expert endoscopic surgeon. He's part of many dedicated multidisciplinary team handling extreme cases in UAE, Middle East, and Asia. He is a robotic specialist surgeon skilled in advanced gynecological pathologies, level 2 pelvicologist, specialized in treating chronic pelvic pain and chronic gynecological conditions, and also, of course, a consultant at the Sunrise Hospital in Solapur in Maharashtra. It's a pleasure to have you with us, sir. Thank you so much for joining and welcome to this program, sir.
Thank you. Thank you so much. And especially on your 50th edition, you remembered endometriosis, and that too in the month of March, which is celebrated as the Endometriosis Awareness Month. I'm really grateful and I'm looking forward to this discussion. Thank you.
Thank you so much, Sandesa, once again. So, as we all say that it's Endometriosis Awareness Month, and today, of course, it's the color of endometriosis we all know is yellow, and that's why probably we both are today decked in yellow to discuss this topic of endometriosis, which we hope we will soon find a solution to prevent it, because this disease of endometriosis, I think, is better prevented than cured. Experts like Sandesh sir will probably say that it can be cured also, but for most of us, I think probably it's little difficult, because to give a complete clearance in a disease, in an endometriosis disease with probably a DIE is quite difficult, and it's not an easy surgery to perform. So to start off with, sir, we
Yes.
would like to initially start off with the basic question that recently we have all seen that there is a rise in endometriosis cases, especially in the younger individuals. So what do you think is the cause for this surge?
Yeah. Indeed, there is a huge rise in the prevalence of endometriosis now. And that's why we routinely call it like the disease of the 21st century. And to explain that, there are many reasons for the rise. But what explains best is the number of cycles a woman faces in her lifetime. So basically, the ovulation, the number of ovulations that happen are responsible for the development of the endometriosis. And why we feel it is rising is because the lifestyle changes that have taken place. The women are getting married late, the first child is delayed, so you end up with more cycles in lifetime. Secondly, the number of children also has reduced, so again the amenorrhea, which is a protective mechanism, is not there. And thirdly, there is less of breastfeeding, so early resumption of menstrual cycles, that again adds to the exposure to the cycles. And also, there are other reasons, like suppose a patient is undergoing ART treatment, there is superovulation with the medicines. So all this adds to the number of cycles. So it's pretty like a mathematical formula that is responsible. And this was very well explained in an article in Human Reproduction in 2019. So I feel this is the reason why we see so many endometriosis patients, and that's why it's become a 21st century disease. And also, Priyankar, you would agree, anywhere on the medical platform, you always see bowel resection, bowel disc excision, and also we find it very difficult nowadays in conferences. Everybody wants to operate only endometriosis, so it's also become a fashion now. So that's why we see a very high prevalence of endometriosis in our day-to-day practice.
Absolutely, sir. I think, as you said, very correct, very appropriately mentioned all the probably reasons for the increase in the rise of endometriosis cases. But also, I think, also to add on that probably now the investigative modalities are so good that endometriosis can be detected as well, and that is where probably the number of the prevalence can we can also say is on the higher side, on the higher note, sir.
True.
So, next, I would like to ask you, of course, a little bit when we start with endometriosis, how do you explain what endometriosis is? And also, maybe a couple of theories which are probably behind this development of this dreaded disease, endometriosis.
Okay, so what exactly is endometriosis? I mean, it is a disease which usually starts from between 15 years up to 50 years. So it's a chronic disease. Okay, and it's an inflammatory disease in which it is hormonally responsive disease. So what happens is actually the endometrium like tissue or the lining of the uterus, which is the endometrium, you have a similar tissue which is present outside the uterus. So basically it can be on the peritoneum, which covers the abdominal cavity. It could be on the fallopian tubes. It could be on the ovaries, bowel, bladder, everywhere. It even spreads to the diaphragm, and it is that's why called a full body disease. So basically, it is the fragments of endometrial like tissues which have a capacity actually to survive, and they have a capacity to undergo inflammation, neoangiogenesis, invasion. And so it's basically a very like a virulent or maybe like a aggressive sort of disease which is present in the pelvis and in distant parts and in the full body. Now, what causes or what theories, if you say, yes, it is a multifactorial disease. And depending upon the different types of endometriosis which we see, no one theory can explain what causes it. If you see the literature has been dominated by reflux theory, where it was presumed that the menstrual blood goes back into the abdominal cavity and these cells actually degrade, but few have the potential to adhere to produce inflammation, angiogenesis, and invade. So basically, a reflux theory is the one which has been most widely propagated. But and this is very commonly seen in patients who have congenital anomalies like the cervix absent or vaginal agenesis, and there is no way for the blood to go out, and then it refluxes into the abdominal cavity. But this theory alone cannot explain why you have endometriosis at distant places or retroperitoneally or inside the ovary. So this theory will now you have endometriosis even in male. So there is no reflux in this situation. So this theory alone cannot explain that. So we have another theory where they say that the normal tissue gets converted or metaplasia into an endometriosis cell. So that's why you have a typical intra-ovarian endometrioma where the cells definitely have not gone inside, but the normal cells within the ovary have got converted into an endometriotic cells. So that is the metaplasia theory. What I like most is the one which was proposed by David Redwine, that is the Mullerianosis theory. And what he felt is that as a surgeon, we always find endometriosis in certain areas of the pelvis, especially the retrocervix, the uterosacrals, or the tracts along the ureter up to the pelvic brim. So what he felt is that when the organ uterus is developing, certain cells get sprinkled and remain in these tracts, and they respond to the hormonal changes, and that's why you have a typical pattern of presence of endometriosis in these tracks. So that is
Right.
one. And of late, the latest one which explains is the conversion to a endometriosis cell, the epigenetic theory, where there is a transformation of these cells to typically the endometriotic cells. So definitely it's a multifactorial, and that's why you have many theories, but no one theory can explain all. But probably given the chance, all theories can give some explanation to different varieties of endometriosis we see every day.
Perfect. So I think so that is very clear and vivid description of how probably the different theories that we have. We have read it a lot, but the thing is, yes, we keep forgetting. But we need to remember probably it is something that is important and that should be known to all of us. Now, next, sir, coming to, of course, any discussion, any clinical disease, of course, we discuss with the symptoms. So, sir, the signs and symptoms predominantly what when a patient comes with, which makes you think that probably this is a case of endometriosis apart from the other gynecological diseases.
Okay. So basically, like I said, it's a chronic disease. The patient can come in any stage of her life. She could be in the just after the menarche, or she could be in the reproductive age, or in the perimenopausal or postmenopausal also at times now. So basically, again, the pain is the main factor because the disease has a invasion theory, or there is a fibrosis, retraction, so and inflammation. So pain dominates this. So basically you have severe dysmenorrhea. That is the main complaint these patients come with. Secondly, you have the pain can be from the other organs. So you have dysuria, or there could be bowel symptoms. Okay, dyschezia. So you have these patients, and in married women, you or even the reproductive age groups, or the you find this dyspareunia is also a very common symptom. And mainly, what I feel is pain alone should not be taken. Exactly what is being reported is very important for me. Suppose a patient comes with a complaint of dysmenorrhea and dysuria. I don't just suspect, but I feel sorry because I find that okay, now these nerves are being involved, and that's why the dysuria is there. So it should not be taken lightly that all pain is similar. some pain could reveal a more difficult or a different story, which where the doctor has to be very anticipatory or suspicious into picking it up very early. So these are the majority of the symptoms. And like reproductive age could present to us with infertility, and very often, because now we are doing with neuropelviology, we find patients being referred for chronic pelvic pain with actually difficult to sit or to walk or climb. They have muscle atrophy, and the reason was found to be endometriosis. So they could actually even represent or present at a very late stage. So the symptoms again is that's why today we labeled it like an enigmatic disease, because there's enigma in every aspect of this disease.
Absolutely, sir. So I think very appropriately, as you said, I think if the eyes will only see what the mind will know, so we'll have to understand that it can affect all parts of the body, as you very appropriately said. And if I can just relate with one of the articles that I was reading, and it said that there was a lady. This was published in the Brazilian Journal in 2022, and they said that there was a lady who had hemoptysis every month during the menstrual cycle, and they did not know the reason. This kept on happening. They tried to diagnose the different modalities and could not diagnose it. Finally, since the lady also had endometriosis, she had severe pain, dysmenorrhea, they planned to treat the patient with LNG-IUS. And
Mm.
LNG-IUS was inserted on that lady. And after 3 months, slowly the hemoptysis also decreased. And that is when they took a biopsy from the lung tissue, it was found that there was endometriotic glands or cells that were present in the bronchial tissue as well, which probably led to the hemoptysis. So, as you said, so very appropriately, endometriosis is a disease of the whole body. You need to definitely have a suspicion in the mind to diagnose it, and then only you
Correct.
can probably treat it appropriately.
Right.
So, next, of course, the important part of diagnosis. There are various modalities. What is your first line? How will you sort of guide the next generation in diagnosing endometriosis so that you are not sort of misdiagnosing and you are going ahead and treating something which probably should not have been done.
Yeah. See, diagnosis is basically clinical. So what happens is we have to listen to the patient, and the clinician has to be suspicious, like I said, to pick up that can this be an endometriosis. So unless we listen and we don't disregard or just gaslight those symptoms, what the patient is trying to tell, especially the menstrual pain, we just try to normalize it, okay? And or at times label her as like a psychological. She wants to miss her school, does not want to give exams, and these all things have to be stopped. So basically, listening and then being suspicious. So you have, for diagnosis from history, is a good algorithms are available, where we have to go through those algorithms and try to actually pinpoint and reach towards the diagnosis of endometriosis. Second is a good clinical examination and correlating. Basically, if you suspect from your history taking, then the next step would be to do a good examination, and then per speculum examination or per vaginal examination, and identifying or trying to reach and feel those nodules, or the fixity of the pelvic organs, or the tenderness to be elicited. And so a good clinical examination is another very good way of picking up and also labeling the severity of the disease. Next modality, after you have done with the clinical history taking and examination, is a good ultrasonography. So we have very good way of doing an ultrasound. So that is explained by the ISOUG. The society has given an IDEA protocol, where you actually screen every compartment, and then we reach a good diagnosis of the endometriosis, also finding out the severity of the disease. So sonography is another very important, but unfortunately it is operator dependent, so it has its own limitations in that. But majority of the times the sensitivity is very good for ovarian endometriomas and beyond. But for peritoneal endometriosis, we really still have a lot of lag in picking up the endometriosis. Next is the MRI. So MRI is a very good modality, because then it is not only operator, it can be reviewed. You don't have to redo a MRI. It can be sent across to the experts to take an opinion. So MRI also for me is a very good modality to diagnose the endometriosis. And we have a lot of biomarkers that are coming up, which are also very sensitive and reliable. So they again are very important in picking up the or diagnosing the endometriosis. So very pretty much we have a lot of things, but we just don't have time. I think that's the reason why we miss so much of endometriosis.
Exactly, sir. So that's what would be my next question, that we have so many diagnostic modalities, but why is still this disease faces a delay in the diagnosis? And before I ask you that, of course, all of us present over here, all in the audience, have to make one note of the fact that we all know that Dr. Sandesh Kade sir is one of the expert endoscopic surgeons who deals with endometriosis very appropriately, not only in India, but also in the Middle East and across the globe as well. But when he talked about diagnosis, he did not talk to us about diagnostic laparoscopy. This is something that all of us will have to keep a note of. We know that in Professor Shafran, in one of the ESHRE conferences, very categorically mentioned that the endometriosis should be diagnosed currently by only imaging and not by a diagnostic laparoscopy. And he also reiterated that Dr. Sandesh Kadesar also reiterated the point that it should not be diagnostic laparoscopy to diagnose endometriosis. Rather, we should go for imaging as the first line modality for diagnosing endometriosis. Thank you so much, sir, for that
Absolutely.
for that point. So next, sir, why then do we face this delay? We have a lot of modalities, but why the delay in diagnosing this disease?
One is actually, like I said, majority of the doctors don't listen to what the patient says or try to actually think or suspect or anticipate. That is one very big important reason. Secondly, basically being a gynecological or a pelvic, to begin with a primary pelvic disease, we have a lot of organs in pelvis. You have the bladder, you have bowel, ureter, nerves, and bones, or all these can overlap because primarily we are depending upon pain as the main indicator for endometriosis. And pain in pelvis could be for any reason. So there is a big crossover of pathies between the orthopedicians, neurologists, proctologists, gynecologists. Everybody could say this is my specialty patient because everybody deals with a pelvic pain patient. And so because you have an overlap, there is a big delay in diagnosis. Secondly, a misdiagnosis, because it has been found that 74% of the patient they have received another diagnosis and not endometriosis. So lot of times you have bowel symptoms which could be labeled as irritable bowel syndrome. You have bladder symptoms, urological symptoms, which could be interstitial cystitis, or there are a lot of inflammatory process which again could be labeled for these patients, or chronic pelvic pain. So that's why with the overlap and because of the multiple organs, we usually end up with a late diagnosis for endometriosis.
Perfect. So I think I would like to quote my father, who's also a senior gynecologist practicing in Siliguri. So he keeps telling one thing, probably the gynecologist of my generation, we consider our right hand to be an ultrasound probe and the left hand to be a laparoscope camera. But we forget the two very important skills that we have. That is number one, to take a good history, and number two, to examine our patient very well. I think that will goes ahead a long way in diagnosing. And we all should remember that the only thing that differentiates us gynecologists from surgeon is these two fingers. Going up to per vaginal examination is very, very important because that will give us a lot of clues towards diagnosing a disease rather than only sending an investigation for the patient.
Also, I would like to say is that see that distribution of patients of endometriosis, it's like in our practice is a pyramidal thing. At the base, you have grade one, which is mainly dominated in adolescents by peritoneal endometriosis. And these peritoneal endometriotic lesions are so small that no modality or examination we can pick it up, and that's why we actually miss a majority of the patients and they
Correct.
face that delay until that ovary goes and sticks to it and produces a cyst. Then everybody picks it up on ultrasound because that has a very high pickup rate, and by now I mean every gynecologist is enabled to pick up an endometrioma, but that is actually a late diagnosis and takes a lot of time, average to be around 7 to 10 years.
Perfect, sir. Thank you so much, sir. Trying to sort or solve this delay in diagnosing endometriosis, we have heard, I have personally heard a talk of yours where you talked about a new technique, which is the salivary diagnostic test. So, would you like to enlighten us a little bit about that, sir? And do you think that it will revolutionize our practice probably in the next decade to come ahead?
Yes, these are my thoughts, which I'm explaining now about the salivary test actually. See, all these modalities which we discussed, the questionnaire to pick up endometriosis early, or actually developing the skills of ultrasonography or MRI, and all these things, laparoscopy, histopathology, all this has been there for years, but never we could reduce this delay. And that's what exactly we want to reduce. So much of awareness has been created now, and people know about it, the patients know about it, even the doctors have been educated about it, but the delay has not reduced. So we were really lacking something, that's what I feel. And these patients were picked up already with the organs damaged, so that was too late. So we need something to pick them up early. And that is the only way which we can really change the whole scenario. Because now what we find is patients unfortunately go into severe disease. They end up with 5 or 6 laparoscopy surgeries, repeated surgeries, a lot of disease remaining back, redundant disease or recurrent disease. So all this is not accepted now, and so something is really going wrong in the management of endometriosis. Maybe some just it is a medical disease like any other, like diabetes or any other asthma, or and it has the same incidence. So, but when so much of medicine is available for the other disease, why we have not been able to give medicine for endometriosis? Just at the beginning, diagnose it and stop it. Don't allow it to progress to this stage. So a lot of thought was being given to this, and a lot of research was happening on this. And especially if you read the paper by Savita Panir, where they actually combined and reviewed a lot of biomarkers. And that was a very landmark paper which was given, which showed that there are certain biomarkers which are related to each process that leads to endometriosis. In endometriosis, you have inflammation, you have invasion, you have apoptosis, you have angiogenesis. So all this has a specific marker. And unless you understand the pathogenesis of a disease and a marker for each pathogenetic reason, and you don't combine them in total, then you will not have a good sensitivity and specificity of this. This is exactly what they picked up, especially this guy, Sofiane Bendafale from France, who actually is a very good surgeon. And I have seen a very beautiful papers by him as a surgeon. But suddenly he comes up with these biomarker papers, and because I used to read his papers, I knew that he will be giving us some enlightenment. And it was a fantastic research that they provided. Is that they studied 109 biomarkers. So it's not a simple one or two, like casually we take CA125, one mark indicator. Here they studied a biomarker for inflammation, biomarkers for angiogenesis. And so in human body, we have around 2600 microRNAs, and out of those 2600, for all different diseases of the body, 109 they could find consistently in patients with endometriosis. So what they did is they said that we will create a signature unless you have 109 biomarkers in a specific range which produces a typical signature of 109 RNAs. They will not label it as positive. So
Okay.
for the first time, we are able to tell our patients, yes, you have endometriosis, or no, you don't have an endometriosis. Please stop coming again to the gynecological clinic. You might be with, go to a gastroenterologist, go to an orthopedician, go to a neurologist, because you definitely do not have an endometriosis disease. So it is so simple, and it has made it, I'm sure this will revolutionize the practice. Now the research actually is going ahead, because now once this is an artificial intelligence technology where which is based on algorithms. Once you know the markers for a particular disease, particular phenotype, a particular pathogenesis, then you can actually predict into what sort of endometriosis this will go. And so we feel that this is a crossroad for a young girl at 20 who starts, or 15, who starts her menses and starts giving symptoms. She will definitely by 30, if you see the average age when a bowel resection is done, is around 30 years or 35. So something goes very bad between these 20 to 25 years. So if we pick them up with this biomarker, this would be very easy for us to stop. And you know what I personally feel is, what would be the treatment for this is just aspirin.
Oh.
Okay, this is my feeling, because inflammation is the
Mm.
biggest cause, I think so. So we could really try with only something very, very simple, but it took us so long to detect. So I think this test has real good potential. Only thing is it should not be misused, and definitely it is not a screening test. You have to have all those algorithms. You have to predict, and only when your ultrasound is not picking up, your MRI is not picking up, but you have a strong suspicion. I feel this girl has endometriosis. Okay, then this test has to be done. So that is one of the place in our clinical practice. And definitely that would add to what you said about Dr. Falcon, is that diagnostic tests should replace operative diagnosis. That is, the laparoscopy should not be used to diagnose endometriosis. And when this came from Eshrei, like you mentioned earlier, it was a big shock for all the laparoscopic surgeons like me. And we really ridiculed and criticized them. Oh, these guys don't know how to do laparoscopy. That's why they want to remove it from the algorithm. But they were really right. This disease can be picked up even without being invasive. So a non-invasive salivary test, I think, will revolutionize this whole practice of endometriosis.
Thank you so much for enlightening on that. So just to take the key point once again from you. So we take a swab of and take the salivary secretion and we send it for the test. That is what you mean? That is for the females. That's what we need to do.
Yeah, so this test has to be advised by a good clinician who suspects it and to give
Yes.
explanation.
Mhm.
Secondly, this test, see what we follow is now, this test was done between 18 to 43 years. So
Mhm.
we send it only those paper, what it suggests and where it was so specific and sensitive. We should not divert from them, those criterias. So you just have to take salivary sample of saliva for that patient, just lock it. It has its own liquid mixer and everything, and just send it across to France. There, they would take this saliva sample and they put it into some next generation sequencing where they produce these microRNA sequences, multiple sequences, 15 million to 40 million reads are produced. Now, this is impossible for a man, a human to read it. So they have used algorithms, artificial intelligence, and that artificial intelligence would study so many millions of reads and find out whether there is specific 109 markers, that too in this specific range. And if all are present, even if you remove 4 5 out of them, the specificity would drop. So they don't give it yes or no unless they do all the 109 and studying all the 2600 at present, which can keep on increasing, and that would really add to more specificity for, as per me. I feel so.
Perfect, sir. So I think take home message from Sandesh sir that is said today. Do not send the salivary test right at the beginning. Take a proper history, do your examination, do your ultrasound, do your MRI, and still when it doesn't come out positive for endometriosis, but you still strongly feel that it is could be endometriosis, do it. Then take the salivary sample, send it across to France, and you might get a report which might surprise you or surprise the patient, and they finally have a diagnosis for the chronic pelvic pain that they were suffering for so long time. Thank you so much, sir, for this input for all of us, sir. So next, sir, I would of course like to come to the treatment options. Now, of course, we know that there are few medical treatment options that have come in as well. But of course, to you, I will come to the surgical part, and I would like to ask you, sir, the surgical options that are there for treating ovarian endometriomas.
Okay. this is a very interesting discussion because that is the commonest presentation we have. And for us, it's a situation what we see in all of the world, all over the world is like it's a hammer and nail. We have a hammer, so everything
And
appears
everything
like
is
a
a
nail.
nail.
Okay, yeah.
Yes.
So we see a ovarian endometrioma, and we just want to remove it, do a cystectomy. That is very wrong. The treatment of ovarian endometrioma will depend upon a lot of factors. The size of the ovarian endometrioma, unilateral, bilateral ovarian endometrioma, what are the patient's expectations, only pain relief, or she wishes for fertility. So, all these factors would decide what treatment is to be offered for that patient for an ovarian endometrium. We usually have around 8 to 9 procedures that can be done on an ovary with an ovarian endometrioma based on what the patient wants actually. So suppose patient wishes for pregnancy, then it has been proved that let it be any surgeon in the world, the best of the endometriosis surgeon, ovarian loss is definitely going to be there if you do a cystectomy. So we have to prevent this ovarian loss. And that's why the all the thinking process, how can we treat the endometrioma yet not reduce the ovarian reserve of that patient? So cystectomy definitely leads to ovarian loss. We need alternative treatment is to treat only the cyst wall, the side on the ovarian endometrioma and not the ovary on the other side of the wall. So what we can do is offer her the ablation therapies, such as the do not do the bipolar ablation is totally a big no in clinical practice, okay, surgical practice. So what we can use is you can do this ablation either by lasers, argon beams, or with alcohols, the sclerotherapy that can be done. Okay, and so we can post these patients. Now, how and which patient to select? Suppose you have a very large ovarian endometrioma in a young girl, then you cannot do an ablation for a very large area. So the best way to treat a large ovarian endometrioma, large ovarian endometrioma, is to do a sclerotherapy. Suppose you have an average ovarian endometrioma, you can choose the ablation, argon laser ablations and therapies. If you have a an endometrioma, but very poor AMH, and whatever surgery you do will definitely reduce AMH further, then in those cases, what you can choose is just an ovarian drainage and cleaning and immediately go for for ART treatment. So and suppose if the patient has completed her family, she's perimenopausal, you can definitely do a cystectomy, especially for pain. Yes, it has shown that pain relief is best with cystectomy, but recurrence also is less with cystectomy. But a definite loss of AMH is a problem. So choose patients who have completed their family, or if it's a unilateral with very severe painful disease, then you can just offer her where the other ovary is a good volume, good antral follicular count. Choose cystectomy on one side. So it based on each case, tailor your treatment, ovarian endometrioma management accordingly, and offer her these treatments, and not just cystectomies.
Perfect, sir. I think very appropriately said because cystectomies, in certain situations, as we know in today's day, small ovarian cysts, we do a cystectomy, we drain out the fluid from the ovary into the peritoneal cavity, and sometimes the implantation of those endometrial glands can increase a disease from grade 1 to grade 4 because of the implantation of these glands and causing peritoneal endometriosis disease. So that is something that we should not do. I very appropriately said, sir. Thank you so much. Now, of course, for you, sir, I think this is the most appropriate question. Who is qualified to treat deep infiltrating endometriosis? I think it will be coming straight from the expert because we all know you as a surgeon who have evolved over the years and currently one of the best deep infiltrating endometriosis surgeons in the country and across as well, sir. And next, you of course will also agree with me that multidisciplinary approach is something that is important. So, which are the cases, or why is it important to do a multidisciplinary approach in deep infiltrating endometriosis cases?
True, a very, very important question, practical question is because see, we feel I am a good laparoscopic surgeon, but are we a good endometriosis excision specialist? That is another thing. Secondly, multidisciplinary, because you might go in and remove what is seen to you, but there is a lot of disease which is behind the curtain. So you need a team who pre-operatively gives you a good score or the locations of this endometriosis disease. So you definitely, who can perform is one who has very well understood the disease, the locations, and its implications in long term. So definitely a team, multidisciplinary team, which I would say would include expert laparoscopic gynecologist to make all the decisions, a bowel surgeon, a urologist. Sometimes with the nerves involved, you could need a orthopedician or a neurologist, neurosurgeon. And post-operatively, pre-operatively, you need a good radiologist. Then post-operatively, you need a good physiotherapist, a psychologist, nutritionist. So all these are, it's like a big holistic approach has to be offered to the patient, not just treat an endometrioma and then wait and she comes back again for another surgery. And that's the reason they end up with multiple surgeries. So we need a big team. Secondly is pre-operative assessment is very important, because we used to find a lot of surprises and then there was no proper consenting. You cannot wake up a patient with a colostomy and not explain to her. That could really affect her career or her job, and that could be very catastrophic for her psychologically also. A lot of stress, mental health issues can develop if you don't pre-operatively explain them, and being realistic that how much we can achieve on the pain relief or fertility enhancement. All this has to be thought of and explained to the patient prior. So we need a good multidisciplinary team. Secondly, there are a lot of complications that can happen. So unless you have a round the clock team, these patients, you cannot operate somewhere a big bowel disease and relying upon somebody who does not do an emergency laparoscopy or a colostomy, or there could be, you need reinforcing of the bowel leak or sepsis that has happened. You need a very high end ICU actually, especially if you are delayed in picking up these cases, they will invariably land up into ARDS and ICU. So we have to be very careful about the complications that can happen. And unless you have really studied the clavin into level 3 complications happening, or some patients really end up with 4 or 5 surgeries till they actually, you bring out the full colon out and hang it out and do a coloanal anastomosis. There are a lot of papers. If you go through these papers of complications and how they are managed, you will find 4, 4, 5, 5 surgeries required to tackle a fistula or a leak. So you really need a good team. You cannot say this happens once in a while and let's involve those doctors at that time. No, you better be well equipped and then only offer these treatments to our patient. So who can do this is perhaps who has and who is in a multidisciplinary team should do it ideally. I feel so. To do
Absolutely, sir.
justice.
That specialized care is something that is definitely required. Specialist teamwork would be the most appropriate word to say over this. And I think for endometriosis, especially, I think it's better to be well prepared than be underprepared and then be sorry for your patient at the end of the day. I think that is
Absolutely,
what we
absolutely.
need to look forward, sir. So, what is the role of robotics in endometriosis disease? Do you feel it's really picking up? Do you think that robotic will be the future, or what is your take on it, sir?
I feel a lot of hurdles into bringing up robotics into practice currently, because now it is not available everywhere. So there is definitely bound to be, and that is usually for any technology that comes. So first and foremost, we have to understand is that robotics is not something new has come. It is either you do a open surgery or you do a laparoscopic surgery. Robotics is nothing but an instrument. Like your OT manager will ask you the previous night, doctor, are you going to use a ligature, or are you going to use a harmonic, or are you going to use a robo? So it's an equipment. So selecting robo as an equipment for specific surgeries is the one that is the current role, and that is going to be the main role in my practice. And it has shown to be very, very effective, especially if we are doing diaphragmatic endometriosis. I mean, the ease with which you can do or the accuracy with which you can do, especially because these arms are so steady. There is no haphazard movement or, overshooting. So all this, just you move out of the vision and all the arms stop. So that much technological advancement and precision has been there, and also the dexterity. So specific indications for me currently are there where robo just outscores the basic straight stick laparoscopy, especially when you have something to go under the uterosacrals. So that is the parametrial. Now, if you see, so much of ureteric involvement happens in endometriosis. So all this is parametrial disease. Yes, we are removing it with laparoscopy, but when it comes to under surface of ureter or lateral or beyond the uterosacrals towards the pelvic floor, then definitely the straight stick laparoscopy cannot reach those areas. So a robotic surgery really works very well in those specific conditions, especially when you have patients. When we see so many patients with sciatica like pain, gluteal pain, or the thigh pain, then we understand, okay, these are the sacral roots that are being involved. So again, the robotic surgery to reach the nerves is a very, very easy and a fantastic method of performing surgery. Prolonged surgeries where you have fatigue, tiredness, or with the expert surgeons, their tremors are not also being there. So it would extend the life of a surgeon and surgical career of a surgeon. So all these are the role for me of robotics in endometriosis, and I really feel it is here to stay, and it will also again surgically revolutionize the way we treat endometriosis.
Perfect,
But
sir. I think so.
currently
I
it's not a must, but it is going to be a very good modality to treat. So I feel, and I would appeal everybody to not run away from it, but accept it.
Yes, I think learn the technology, and when you have the facility, use it for your
Yes.
appropriate patient is something that we can say. Thank you so much, sir. Now, finally, of course, the myths and misconceptions. That is what usually becomes the most important confusing point for most of us. So, sir, common myths and misconceptions that you would like to put forward, because based on that, we can probably diagnose, we can counsel our patients well, and treat our patients well as well.
Oh, plenty of myths. Full disease is surrounded with lot of misconceptions and myths right from the beginning, So, normalizing the patient, the girl, saying that this is a normal pain. Your mother had it, or your sister had it, your aunt had it. So, it's a common thing. So, saying that it's normal. So, this normalization is one myth which happens in many of the families. Secondly, doctors ignoring the patients, because for many doctors, if there is no pain, there is no endometriosis. No, a lot of the patients can be minimally symptomatic or asymptomatic. And so that is another myth which is there. For the extreme age, if you go from adolescent to perimenopausal, is just do a hysterectomy and everything will be settled. Well, endometriosis is outside the uterus. So removing the uterus will not solve a disease which is outside the uterus. So again, that is a big myth which is there. A lot of doctors would suggest, or gently and mildly, they tell the parents marry her off, and pregnancy would solve her endometriosis. So it just these are all myths. These are not the treatments for endometriosis, or putting everybody on OC pills and saying that, oh, once you give OC pills, the disease will go. Well, it never goes. It will just mask it,
Suppressed.
pacify it symptomatically. So these are all the myths which we commonly face. And especially even post-menopausally, we find a lot of patients, they undergo some surgeries, and all these myths lead to recurrence or redundant, or repeat surgeries that are happening. So plenty of myths that are there in the practice.
Absolutely, sir. That is why probably we need to understand in this endometriosis awareness month that awareness has evolved over the recent few years, and it will continuously get evolved because science is an evolving subject. And I'm sure at the end of the day, we will come to a way where we can make our patients and their parents more aware of the disease and how to take it forward. Now, finally, we'll end by taking key messages for our patients and healthcare professional, and also probably a couple of awareness tips that you have come across regarding endometriosis evolving over the last couple of years, or maybe a few more years more ahead.
Okay, the tips for the patients would be is that patients should start believing that yes, you really have pain and that is real. So believe in yourself. Don't listen to somebody normalizing your pain and trying to prove it to you that there is nothing, this is normal. You believe, okay, you find that this is something different from your colleague, and so just don't accept their pacification. Okay, that is one thing. If somebody is dismissing your symptoms, change that doctor. Go for a second opinion. Okay, be vocal about your symptoms. Be vocal at in your house and just pester your parents and make them take you to a good specialist for a second opinion, or find for yourself, advocate for yourself, find a good endometriosis specialist in your town and let them actually examine you and find out whether you are really suffering from endometriosis or no. And if you are really getting affected, your school is getting affected, your career is getting affected, please don't bend down to all these myths and all these factors. You could ask for more diagnostic modalities, and be it anything, a good ultrasound, a good MRI, a good biomarker test, or and finally, unfortunately, even if it's a laparoscopy now, but don't sit back, don't leave your college because we have seen patients losing their career or even their jobs, or at workplace they are not being understood. So be very very vocal about it. And for the policymakers or for the job givers, we should understand that these patients really need special management during this pain period, no? So they should be offered some excuse or some light work, because there is really a lack of concentration. Their efficiency is hampered. So we have to be at least empathetic towards these patients into understanding their problems and expressing our concern. So at school, the teachers, the principal, they should be aware that yes, endometriosis can be a reason for their absenteeism or their lack of concentration or poor performance in exams. So that is another thing. Even for the policymakers, it's very important. Such a common disease, as common as diabetes and asthma, like I said, but very poorly funded. No research, no RCTs, no long-term programs, and absolutely apathy towards this disease because of lack of awareness. So we really have to move these patients, and I'm sure Foxy and Sunita madam would. She's currently, like you said, she is with the chief minister there. So she is getting a very good platform to really mobilize these policymakers and make this very easy. And finally, the tips for doctors. I mean, please lend your ears to these girls. Be suspicious about it. It could be endometriosis. Think, at least give some time to think, is it endometriosis or not? And then try to use the best modalities and pick up the diagnosis. So these are few of the tips to actually make early diagnosis and prevent her wandering and suffering for many years in her life.
Thank you, sir. So I think as you very appropriately ended this discussion, I think it's very important for all of us to know. Some of us, as I said at the beginning, also the eyes will see what the mind knows. I think similarly for us also we have to accept at some point of time, like if there's a patient who has come to us, we suspect it's a case of DIE, and we will probably not be able to operate, and she probably requires a surgery. Some instances we think that okay, we will give medical management because we are not able to operate that disease. That should not be what our mentality should be. I think we should be more open to accepting the fact that we have limitations. All of us have limitations for that matter. And we will limit ourselves to what we can manage and what we can treat. And if we cannot, we definitely have our colleagues who operates very well, who can give better management to the patient, because ultimately we need to all remember the Hippocrates oath which we took during our joining our medical
Mm.
journey, where we said we will never harm our patient if we at least cannot benefit them. So we cannot postpone the disease, we cannot keep the disease at bay, but rather give the appropriate management. And when the appropriate management is not possible by us, refer them to someone who will be of more use to the patient than us. So I think thank you so much, Sandesh Kadesa. It was a pleasure talking to you today evening. It was pleasure learning from you. And there were so many very valid tips that we took from you today, sir. Thank you so much. We would like to have you again sometime in this podcast series or in some other talks that we will conduct in future. But thank you so much for now. Thank you for updating us regarding the endometriosis, the enigmatic disease, especially in this endometriosis awareness month.
Thank you. Thank you so much for the invitation. And I too really loved this. And I would also end up with the same note that you said is do no harm. So thank you so much for having me here and looking forward. Thank you.
Absolutely a pleasure, sir. Thank you so much once again. Thank you on behalf of Sunita ma'am. Thank you on behalf of the entire Foxy team for
Yes.
being here today, sir. Thank you so much.
Yes. And appreciations to Sunita ma'am and your team. Thank you so much.
Thank you, Sandesh, sir. Thank you so much.